symposia, which will run up to 26 from today, 24th November to 26th of November, Adolescent Health Symposium. The subjects of discussions will vary from one speaker to another, but all in essence is about these young people, the adolescents and the other young people that we will be referring to. And this is a population that constitutes a very high proportion in terms of the normal global population, about 1.8 billion as per the data shared in 2019. This is the age 10 to 24, that's for the young people as such. But remember the adolescents itself are from 10 to 19 years. This is a dynamic population, quite in transition as it's known. And they're viewed generally as resources to be nurtured and supported, but not problems to be fixed, as sometimes maybe people look at them. Our media, local and international media, watch with the news about the adolescents and the young people. If it's not about the teenage pregnancy, the child marriage, the mental health issues, suicide, drug and substance abuse, the HIV prevalence, even especially looking at the new infections, the violence, malnutrition, amongst many other issues that affect them. So we'll be hearing from various speakers on these such subjects. And first to start us off will be Dr. Christine Wambugu, who is the head of the Adolescent and School Health Program at the Ministry of Health. So welcome, Dr. Christine. Is Dr. Christine with us? Agnes? I don't.
In a minute, she's been able to share with us. Dr. Christine, are you able? Okay.
I'm not seeing on the.
Not yet, but she is on email. Yes, just a minute.
Okay, she's on the side of.
She's going to put it right now.
Okay.
Dr. Christine, you can be able to hear us now.
All right, go ahead. Welcome, Dr. Eri.
Okay, thank you so much. Good afternoon. Sorry for that short hitch. I was not a panelist yet, so I was not able to share my screen. As Dr. Okoro has introduced me, I'm Dr. Christine Wambugu Gare, currently heading the Division of Adolescent and School Health at the Ministry of Health in Kenya. I will be presenting on adolescent health. Why the fuss? So just to put us in context, about a quarter of Kenya's population are adolescents. These are about 11.6 million children, 6.3 million between the ages of 10 to 14, and 5.3 million between the ages of 15 to 19. And why the fuss? We know adolescents are generally healthy, or are they really healthy? So this is some data that has been gotten from estimates of UNICEF. And to the extreme right, we have global trends. In the middle, we have trends for Sub-Saharan Africa. And to the extreme left, we have the Kenyan trends. And here we're looking at risk factors for adolescent health and just looking at the prevalence of nutrition risk factors. I apologize, I think my slide got cut off at the bottom, so we're not able to see the legend. But when you look at The bright blue, that is the prevalence of overweight. The red is the prevalence of obesity. And you can see that overweight and obesity are in the increase, and more so among adolescent girls aged between 10 and 19 years of age. Other risk factors, this is in the Kenyan context only. We have prevalence of heavy episodic drinking in adolescent boys. These are 10 to 19 years old, of 12% and 2% in girls, 13% of tobacco use and 7% in boys and 7% in girls, and a very high prevalence of insufficient physical activity in both boys, adolescent boys and adolescent girls. And when we look at years of healthy life lost due to disability among adolescents, and we compare the global data, the Eastern and South African regional data, and the Kenyan data, we can see an increase in mental health issues that are affecting our adolescents and causing years of healthy life lost due to these disabilities. Of note, you can also see issues around skin diseases. And for the girls 15 to 19 years, we're seeing issues of gynecological diseases among this age group. When we look at the causes of mortality, and we compare global East and Southern African region and Kenya, we see we have the usual communicable diseases, HIV and AIDS being among the leading cause. And for adolescent girls, maternal conditions. We're also seeing diarrheal diseases, parasitic and vector-borne diseases. And then of the non-communicable diseases, we see road injury causing significant death among adolescents. So when we look at general demographic indicators and contextual factors, we can see that the adolescent birth rate in our country is way higher than, it's almost double, actually more than double that of the world at 96 per 100,000 girls, 15 to 19 years, compared to the global rate of 10 per 100,000 girls. And our adolescent mortality is also slightly higher than the global rate. And the population living below the poverty line at 36%, while globally is 18%. And when we look at issues of moderate to severe food insecurity, in Kenya, we're at 57% compared to the global average of 19%. So why the fuss about adolescents? Adolescents are the greatest resource for society to thrive. And the big investments that we're talking about making in adolescent health is around having healthy adolescents now, having healthy adolescents in future, and having these healthy future adolescents siring a generation of future leaders and future citizens. So just to give an analogy, we are all interested in money, and how compound interest works is exactly the same way investments in adolescent health works. So for the purple, we see that's the principle. When you put in regular deposits, you're able to compound the amount of interest you're able to grow on your investment. And this is similar to adolescents, where the principal, who is the adolescence, we are seeing is a child who has survived through the fetal period, the neonatal period, childhood, and the preteen period. And the deposits that we're supposed to make around adolescent health, they're not only towards the physical that we tend to focus on, that is nutrition, body systems, and health systems, but we also need to look at them holistically, looking at their emotional well-being, their social well-being, their intellectual well-being, and also their spiritual well-being to have a whole-rounded adolescent. I think this is a very common slide that we often use to show the irrational behavior that adolescents have, because the judgment area, the prefrontal cortex, is the last to develop in adolescence. So we tend to associate adolescents more with risk-taking and pleasure-seeking, and thinking that they do not have too much rational thoughts. This is both a good thing and a bad thing. It's a good thing when we consider these positive spirals during adolescent brain development. And an example of this positive spiral, if we can look at the arrows at the top, we're looking at biological changes that increase the tendencies to explore, take risks, and what we're trying to say is that adolescents can explore healthy versions of risk-taking. And these healthy versions of risk-taking need support from an adult or a guidance mentor to these adolescents. And this can actually be used to improve self-confidence, supported risk-taking within a learning context. So the risk-taking activity of the adolescents is not necessarily a bad thing. We can use it to create these positive spirals during adolescent brain development. And an example of the negative spirals that we want to discourage are, say, for example, the adolescents want to tend to stay up later, be too much on their phones, and then they get sleep deprived, and then they get affected on their emotions and the attention span in class, and then their overall health is affected. So those are the downward spirals that we want to avoid. So the risk-taking is not necessarily a bad thing. It's only that we need to channel it to a positive spiral. So these are some of the investments that we can make to adolescents. When we look at the green at the top, those are protective factors from adolescents. And you can see that they begin all the way from preconception. So this is the adolescent when they're still within their mother's womb. So the mother needs to have responsive care, then have skilled birth attendants, have, once they give birth, this adolescent as a child has to have social and group support, birth registration, get all their immunizations, support for early childhood development, school achievement, parity in education, self-learning environments, ICT literacy, and then universal access to health generally, not necessarily sexual reproductive health. So we need to avoid these negative spirals or the vulnerability factors that we see at the bottom. So a mother who's maternally deprived will give birth to a child with neonatal risk, low birth weight, prematurity, and then have malnutrition, poor growth. And then more often, this is within the setting of poverty. Then you have issues around child labor, commercial exploitation, child marriage, and then issues around, what we've been grappling with as a country, teen pregnancy and all, which actually give negative impact to adolescent health. So this triple dividend, we're looking at the benefit to this adolescent. And I'll give an example of the National School-Based Deworming Program, where the government of Kenya has committed to deworming 6 million school-age children in counties that are at high risk. There was a study done by the Nobel laureate, Michael Kremer, who looked at children who had received 2 to 3 years of deworming treatment, and it was a longitudinal study that the participants were followed over a period of 20 years. And the study found that this deworming reduced school absenteeism by 25%, impacting the children who were treated, but also those who were not, obviously by reducing the prevalence of worms within the school setup. And among females, deworming increased the rate of passing national primary school exams by 9.5 percentage points. And later on, as these children were followed up, they were found to have 20% higher earnings. They increased their income by 13% as adults compared to children who were not dewormed. And the new Kramer study found that for every dollar spent, each person who received the treatment reaped economic benefits worth on average 25,000 Kenya shillings, even in the most conservative scenarios. The benefit of having a healthy adolescent to the family is well seen by seeing the caregivers take less time off work for home-based care or hospitalization. And then in turn, they get sustained or increased wages. There's more money available to support other family needs, including school, fees, rent, food, clothing, and other family needs. And then when we go back to the example of the National School-Based Deworming Program, the study also found that deworming dramatically improves cognition, equivalent to half a year of schooling, in untreated younger siblings due to the spillover effect of investment to these adolescents. And to the economy, there are some studies also that have been done. And just to quote the National School-Based Deworming Study, it showed that for every dollar spent, there are fiscal benefits due to increased tax revenue equivalent to about $16. And other studies that has been published through this work of UNFPA in 2014, the power of 1.8 billion adolescents, there's a tenfold return on investment through better educational attainments, workforce participation, social contributions, and at least $100 billion in demographic dividends in investment in early childhood and adolescent health and development. In sub-Saharan Africa, for example, there would be at least 500 billion a year, equivalent to about a third of the region's current GDP for as many as 30 years. And this is what we're calling the grand convergence in health, giving all women, children, and adolescents an equal chance to survive and thrive. So that is also another schematic showing why we need to invest in this, in the adolescents. And this is just a summary of the global strategy for women, children, and adolescents health, which is what the Ministry of Health has also been using to benchmark as we create our own strategies that I will be presenting in my next presentation. And this global strategy gives three objectives of surviving, thriving, and transforming. Where surviving, we are looking at ending preventable deaths, thriving, ensuring health and well-being, and transforming, expanding, enabling environments. And all these interventions that have been outlined in this strategy are based on those SDGs on health, quality education, gender equality, reducing inequities, and other SDGs related to the political, social, economic, and environmental determinants of health and sustainable development. So I hope that has been enough of a case of why the first, and I'll hand over back to Dr. Dan Okoro. Thank you.
Yes, thanks a lot, Dr. Christine, giving us the key highlights on why the fast. I believe we've gotten a question, the key highlights from there, from the presentation. I would suggest that unless you want 1 minute or two, but you have saved us 5 minutes at least, even if as much as we started a little late. But here we are, so that you tie it together with the next presentation, which we'll be speaking on the Ministry of Health Kenya's initiative to improve adolescent health. I believe you can, so that you we can link together on that. Back to you, Christine. And then just remind ourselves that make your comments, your questions on the Q&A section. To you, Dr.
Okay, thank you, Doc. Just give me a minute to share my next presentation. Thank you.
All right, as you prepare on that, just a few recap on some of the items that I picked on. That's generally adolescents are considered healthy, but there are numerous other challenges that they do face. And they are quite a good resource to invest in, looking at them as the future of any nation. Applying the financial lens, the deposits, consider them as a principle in which you need to deposit, and there's a compound interest that you'll gain as they grow up in the future, looking at the general well-being. They need to be supported to create positive spirals, avoid the negative trajectories. And also, I think one of the things in this area, especially looking at the negative ones, which we grapple with, I have adolescents in the house, is managing their time on the digital gadgets, technology. How do you manage that? And then also the importance, the value of investments in the continuum of care, from the preconception, looking at the prenatal care, all the way to the time the mother receives skilled birth attendance, the immunization, the other care in terms of including breastfeeding, amongst many other things. And also highlighting on the study by Kremer, looking at one of the key interventions, deworming, which sometimes many may belittle, and has got a great investment, great returns of about 2,500 shillings for every deworming initiative that is taken. And of course, lastly, talking about the growing convergence in health, when we give a chance to our women, the children, and adolescents to survive and thrive. So I can see you're back online, and over to you, Dr.
Okay, thank you so much, Dr. Okoro. I'll begin to make my second presentation on what is the Ministry of Health doing to improve adolescent health in Kenya. So I'll briefly look at policies, strategies, and guidelines that are currently available on adolescent health. And for us at the Division of Adolescent and School Health, we are guided by the Newborn Child and Adolescent Health Policy, the Adolescent Health Strategy that is currently in draft but about to be launched. Then we have our School Health Policy and Guidelines, a School Health Strategy that is also in draft that I will give a brief overview about. We also have the National Adolescent Sexual and Reproductive Health Policy 2015 that is currently under review. And I think my colleagues will also be making a short presentation about that later on during the symposium. We have the Mental Health Policy 2015 to 2030. We have the National Guidelines on Alcohol and Drug Use Prevention by NACADA of 2021. We have the Menstrual Health Management Policy and Strategy. And then we also have the National E-Health Policy. On guidelines and action plans, we have adolescent health guidelines that are in draft. We have the school health guidelines that I'll give a brief overview about. We have the guidelines on health and safety protocols for reopening of basic education institutions amid the COVID-19 pandemic. This is by the Ministry of Education of 2020 that were developed jointly together with the Ministry of Health. We have the guidelines for provision of adolescent and youth-friendly services in Kenya, 2016. We have the National Protocol for Treatment of Substance Use Disorders in Kenya, 2017. We have the Adolescent Package of Care that was developed by NASCOP in 2014. We have the National Physical Activity Action Plan, the Violence and Injury Prevention Plan, and then we have guidelines for conducting adolescent HIV, sexual and reproductive health research in Kenya of 2015. So I'll give a brief overview about the adolescent health program. And just to say that initially, we didn't have too much data about adolescent health. Mainly, it's not because the data was not there, it's just that the data was not disaggregated for us to tease out those age groups of 10 to 14 and 15 to 19. So this adolescent health survey was designed to give us data that would inform programming and policy development around the issues that are affecting adolescents in Kenya. We've been looking at estimates, like the data that I presented from my previous presentation was about estimates and projections that have been done using various different studies and the KDHS and extrapolations using modeling that is not really data on the ground. So this was set for us to be able to get the actual context of what programming we should do for adolescents in Kenya. And there are four main objectives: to look at the status of health and well-being of the Kenyan adolescent, assessing the service provision of health services to adolescents at the health facility, at the schools, and at the community, and then to determine the coverage of health services to adolescents in the country. Are these adolescents able to access these services? And if not, it takes us to the fourth objective: to determine the barriers and enablers of provision of health services to adolescents. And the survey was structured in three main questionnaires. The first household survey, was looking at the social demographic characteristics of the adolescents in the household, issues around water, sanitation, and hygiene at the household level, morbidity and mortality, ASRH and HIV, oral health, physical activity, nutrition, mental health, alcohol, tobacco, and substance use, injuries, which included road traffic injuries and interpersonal violence. And then we also had another team that went to health facilities, and they were looking around the system building blocks around adolescent health service provision in the facility, looking at issues of leadership and governance, presence of policies and guidelines at the health facility, support supervision on adolescent issues, human resource capacity and trainings, infrastructure, medicine and medical products to support provision of adolescent health services. And then even just looking at the interaction of adolescent health service delivery, exit interviews were done to adolescents and adults at the facility to ask them how they found the service and what they felt could be improved. The third aspect of the survey was looking at the school health, where we went to schools and we were looking at water and sanitation facilities, availability of medical personnel at the schools, availability of clinics and sanatoriums, as well as medicine and medical products in the form of first aid kits and the contents of the first aid kits. And then availability of school health clubs, guidance and counseling teachers, and what health topics were covered in the school health clubs. So this survey report is about to be launched, and it is going to inform the ministry and other development and implementation partners in designing responsive adolescent health programs in the country. So this is the adolescent health policy that we were working on. We've been using the Newborn Child and Adolescent Health Policy 2018. And the adolescent health strategy is looking at 5 main thematic areas. One, we want to empower adolescents as critical partners in their own health. Then we are looking at sustained commitment, leadership and advocacy, and coordination for provision of adolescent health services. And we are also looking at empowering parents, teachers, and communities for a shared responsibility with regards to adolescent health. We are looking at ensuring access to equitable, quality, and adolescent responsive health services. We're looking at strengthening systems for data collection, monitoring, and evaluation, including surveillance and research. And what we are proposing as the coordinating structures, at the national level, we have the Adolescent Health Interagency Coordinating Committee that is coordinated at the level of the Director General, together with development and implementing partners. Then we have a steering committee that is at the level of the head of the directorate, because we do realize there are so many divisions that touch on adolescent programming. We have adolescent HIV, we have division of violence and injuries, we have division of reproductive health, we have the tuberculosis program that has a child and adolescent TB component, and so on and so forth. Then at the national level, we also have now the National Adolescent Health TWG, where we have at the level of the head of the Division of Adolescent and School Health, together with the MOH adolescent leads in those various divisions that I have mentioned. From here, we want to cascade this down to the county, sub-county and facility level. I think previously the RH focal people have been taking, have been participating a lot in adolescent programming, but we are looking at a place where we can have the child and adolescent health focal person together with the RH focal people and the county director of health, the sub-county MOH, and the MedSup taking an active role in programming for adolescent health at the county, sub-county, and facility level. So for the school health program, we do have our school health policy and guidelines 2018. And these school health guidelines outline those 8 thematic areas: values and life skills, gender growth and development, child rights and responsibilities, water sanitation and hygiene, nutrition, disease prevention and control, special needs, disabilities and rehabilitation, school infrastructure and environment, health and safeguards, and other cross-cutting issues like COVID-19. So the school health strategy that is currently under development is looking at adapting this initiative of making every school a health promoting school. This is an initiative by WHO, UNESCO, and UNICEF. And these are the documents that are available for country adaptation. And this is a process that Kenya is embarking on at the moment. So we have case studies that we can look at. They're the WHO guidelines on school health services, and then the implementation guidance on how we can make every school a health promoting school. And this is the direction that Kenya is going for the school health program. And the 8 global standards in this initiative for making health promoting school, making every school a health promoting school, is looking at government policies and resources. And as you can see, for Kenya, we already have our school health policy and guidance. We are looking at school policies and resources. So are these guidance, to what extent are they cascaded down to the actual user? And then we are looking at school governance and leadership. So it's not just enough for them to have the guidance. They need to be able to provide leadership and coordinate, data, finances, and trainings for them to be able to implement this initiative. Then we're looking at school and community partnerships. We recognize that schools do not exist as an island, and they need to be supported by the community and the parents within which they are found within the community. So looking at issues around that. And then now where the rubber meets the road, issues around the school curriculum. For Kenya, I think we are already ahead because the Ministry of Health has been working together with the Kenya Institute of Curriculum Development to put in health issues in the curriculum all the way from grade 1. And right now, I think they are programming for, I think, grade 13. So we are looking at putting health issues there. And it's not only issues around sexual reproductive health. Something as simple as instead of telling the children in grade 1 to count sweets, we are telling them to count apples. Those things subliminally institute healthy practices in these children. So that's what the Ministry of Health has been doing together with the Kenya Institute of Curriculum Development. And then we're looking at school social emotional environment. I think there has been a bit of neglect in mental health issues in schools, and having trained guidance and counseling teachers, or if they're not there, linkages, strong linkages to where these students can be able to access this service. And I think with the issues that we are seeing right now surrounding the frustrations of the learners, this is something that you can see is given a lot of prominence in this new initiative. And we hope we'll be able to adapt this for the benefit of our learners in schools. And then we're looking at school health services. Traditionally, we've been doing a lot of segmented, fragmented issues. Like I mentioned about the school-based deworming program. We also have a weekly iron and folic acid supplementation program that we give to, it was a demo project that was being done in areas of high anemia prevalence. And we want to now holistically bring school health services. We've also been doing advocacy for HPV vaccines in schools, but now we want to bring it as a package that we can offer holistically to all schools under this 8th standard for making every school a health promoting school. And last but not least, the school physical environment. As you saw from our school health guidelines, we already have a component of this. And here we are looking at issues around water, sanitation and hygiene, adequate ventilation and natural light to prevent some of the communicable diseases that we are now seeing, and issues around firefighting equipment, prevention of drowning in schools next to large water bodies, and so on and so forth. So holistically, that is the initiative that the Ministry of Health is moving towards, making every school a health promoting school. So the school health coordinating structures are slightly different from those of the adolescent health program because we program hand in hand with the Ministry of Education. So this necessitates our cabinet secretaries, both Cabinet Secretary of Education and Health, to have to be the heads of the National School Health Interagency Committee. You can remember from the adolescent program, it was at the level of the DG, but here, because we're talking about interministerial collaboration, it has to be at the level of the cabinet secretary. And then the school health technical committee is headed by both permanent secretaries. And then we have the steering committee at the level of the head of the director general, and then the school health secretariat at the level of the head of department, and then and this cascades also to the division of adolescent and school health. And then from there we have the county, sub-county, the ward, and the actual school health committee that also gets feedback from the students and pupil councils. So what else are we doing cross-cutting for adolescent and school health? We are having a joint monitoring and evaluation framework that is currently being developed. We are getting support from some of our development partners to do this. And we are doing this based on the global action for measurement of adolescent health. And this is a collaboration between WHO, UNAIDS, UNESCO, UNFPA, UNICEF, UN Women, World Bank, and the World Food Program, because we realize that adolescent health indicators cut across all these areas. And this is so that we can promote a harmonized adolescent health measurement, so that we can, for us as a country to be supported to collect useful data to track progress in the improvement of adolescent health programs. And meanwhile, even as we are doing this, we are promoting the age disaggregation of data. And the suggested disaggregation is male and female 10 to 14, male and female 15 to 19, and male and female 20 to 24. And that will form the backbone of our M&E framework. So also, what is cross-cutting? We are looking at our division's communication strategy, and this is supposed to highlight key issues to be addressed for positive behavior change communication. And the target audiences are adolescents themselves. You remember from our adolescent strategy, we want to empower adolescents to take charge of their health. We are also targeting parents, and we're also targeting community gatekeepers, that's religious leaders and other community leaders. And the modes of communication, we have our conventional media, the TV, radio, and print media, IC materials, social media. We have websites and mobile messages that we're also using to target this behavior change communication. And then the USSD, which is the Internet of Good Things. This is an example of an initiative by UNICEF. And the beauty about this is that it does not need a data charge, so we can be able to push positive health messages to adolescents who have access to mobile devices through this, even without a data charge. So just to sum up, as the Ministry of Health, we do not work in isolation. We work with partners to be able to reach adolescents. And these are some of the toll-free lines that are currently existing so that adolescents can be able to reach out with any issues that they have. We have Nairobi County having a toll-free line, the COVID-19 of the toll-free line of the Ministry of Health that's manned by Safaricom. We have our gender-based violence hotline of 1195. We have the Kenya Police Emergency Hotline that we also link up with. We have the Doctors Without Borders toll-free line for sexual violence, the LVCT toll-free line, and then also the NACADA toll-free line in case someone needs to talk about drug and alcohol addiction or use. So with those few remarks, I hope I have holistically covered some of the initiatives that the Ministry of Health is doing towards adolescent health. So thank you, and back over to you, Dr. Okoro.
Thanks, Dr. Christine. Always nice listening to you, the comprehensive presentation on what the Ministry of Health, and more particularly looking at the Division of Adolescent and School Health, is doing. Hope many have heard, and maybe if at all there'll be comments, questions will come at the tail end of this. Colleagues, ladies and gentlemen, once again, thank you for joining us for the first day, day one of this 3-day symposium, Adolescent Health. So our next speaker is Dr. Beckham Duga Magwa, who is a senior fellow and research and program advisor at USAID's Star Fellowship Program at the Public Health Institute. He will be giving us the international perspective of the adolescent health in terms of the initiatives. Subsequently, be followed by the county perspectives by Honorable Dr. Mbai, who will join us shortly. There's a few technicalities, but he will join us a little later. So welcome, Dr. Magwa, my senior.
Yeah.
So Christy, pull down the screen.
Thank you very much, to the organizers of this workshop and for allowing me to participate. I hope you can all hear me well this afternoon. I want to kind of like trying to get my screen to share. Can you see my screen?
Yes, we can.
Yeah. Again, thank you so much for the organizers of this workshop and
Maybe
for inviting
Dr. Magwa, put it on us slide mode.
I'll put it on presentation.
Okay, yes, presentation mode. Thanks, thank you.
Yeah. Again, thank you for inviting me to share some of my perspectives on this important topic today. I would first of all like to thank Dr. Wambugu for giving us such a great foundation and starting of this workshop and laying out some of the key issues that I may also touch on briefly as we go along. When I was thinking about this, I kind of really tried to avoid having to bore you with data and also building on Dr. Wambugu's presentation. She did share quite a lot of that. So I might take a slightly different perspective and just give you some highlights and some thoughts that, are going on at a global level and discussions that are going on at a global level. Well, as Christine did mention out, our future depends on how prepared our youth will be. And this is, borne out when you do kind of appreciate and understand that today, 27% of, the world's population is youth. And more than 90% of these live in developing countries, as Christine did point out earlier. She also did refer to the data disability adjusted life years. And when you look at this, they account for 15.5% of the total disability adjusted life years, experienced, by the global populations. And Africa has, the highest when you look at this. And of course, Kenya being in Africa is likely to have a slightly higher proportion of this, as Christine did point out. Now, also what is important for us to note is that this disability adjusted life years rates are higher among girls than boys. So again, as Christine did point out earlier, being sure that we are looking at this from an equitable lens, and also a gender lens is also important, knowing that girls are likely to be more disadvantaged than boys when it comes to this. And again, some of the key causes also did allude to them, and of course, neuropsychiatric disorders accounting for the vast majority of this disability adjusted life years. Now, I'd like to just kind of like highlight a couple of examples, of some of these health issues that young people are having to deal with. Again, Christine did talk about mental health, but put it at a global perspective. One sees that, nearly 1 in 7 of the 10 to 19-year-olds experience some mental health disorder of some kind at any given point in time. And this accounts for about 13% of the global burden of disease in this age group. Now, depression, anxiety, and behavioral disorders are among the leading causes of illness among adolescents. And suicide is very common, as we've seen even in the recent report by, I think it was the BBC, which did a special series on mental health in Kenya, reporting that nearly 500 young people do die as a result of suicide in this country alone frequently. And the consequences of failing to address adolescent mental health are obvious, that these will show up in the future in terms of limiting opportunities for these young people to be able to lead fulfilling lives as adolescents. The other example that I wanted to kind of highlight is to kind of go to the out of mental health and talk about sexual and reproductive health. Again, we also know that sexual and reproductive health is a major problem, particularly so for young girls. And as we know that approximately 12 million girls aged 15 to 19 years give birth each year in the developing world. And 10 million unintended pregnancies occur among these adolescent girls, and complications of pregnancy and childbirth are the leading cause of death among the 15 to 19-year-old girls globally. Now, one might ask why I did kind of choose those two examples to highlight. And the reason I did that is to kind of lead into the next slide there, whereby to say that whereas these diseases do tell us something, that mental health is prevalent, is high, it has all these complications, and also adolescent pregnancies are high and they have severe complications. But to remind ourselves that those are just symptoms. They kind of tell us a little bit about what's happening in the society, but they're just like a window for us to kind of examine and see what is it that is really contributing to these conditions occurring, particularly so among the young people. And here again, you have to look at it from three perspectives. That there are three major attributes that contribute to disease and to the disability adjusted life years, not only in adolescents, but in all populations globally. One is the agency. If people don't have the agency to kind of like deal and respond to some of these issues, then of course they are likely to kind of have be exposed to and suffer severe consequences of these diseases and disabilities. And the social position of the individual, where they are in terms of societal position, is also important in terms of exposing them and also enabling them to deal with these diseases when they do occur. And all this has implications for the health and well-being. Now, if you dig that a little bit deeper, when we talk about agency at a global level, we kind of like try to break these things down and think about them and say, what do we really mean? When we talk about agency, we talk about knowledge, we talk about social norms, we talk about policies, because all these are going to impact the individual's ability, whether they are young or old, their ability to be able to avoid or prevent these conditions, and also to experience health and well-being. Because if they lack the knowledge, and if the social norms within which they live are not supportive, then they will not be. And the example I'll give here is, look at, for example, education. Christine did allude to one of the entry points that the ministry is using the schools as the center of the entry point for their interventions, which makes a lot of sense. Because then if young people are enabled to go to school, they will be able to learn about these conditions and whatever it is. And if there are social norms that enable, these young people to continue and stay in school, because we all know that in many societies that we live in, girls are deliberately denied the opportunity to continue in school because of social norms that exist within those communities. But if they are enabled to continue and go to school, then they will be able to kind of like prevent and deal, with the consequences of some of the exposures that they get. And policies, again, Christine did allude to that. If you do not have supportive policies, then the individuals cannot have the agency to be able to even seek care or to even know what their rights might be. Now, when we talk about social positioning, we are thinking about, opportunities for employment, access to assets and opportunities. Again, if young people are not given the opportunities to be able to kind of grow and exploit their potential, they are likely to remain in social positions that do not support them to be able to resist or prevent disease conditions or even deal with the consequences of those conditions. And we know that in many of our countries, unemployment and inability to access assets is a great challenge for young people. And without addressing that, I don't think that we'll be able to realize that. And then when you talk about health and well-being, even when you have got agents and you have got the social position, but if the services are not available or accessible or affordable for the young people, then they will not be able to seek those services to be able to kind of mitigate the consequences of some of the health conditions that they may be experiencing. So again, I think when you're thinking about addressing adolescent health, if you look at it and think about it comprehensively, that it does not exist, it does not exist in a vacuum. As you can see from that slide, young people don't exist in a vacuum. If you put them at the center where we're talking about the individual, you can see that surrounding that individual, there is what you call the microsystem, whereby you've got the family, you've got school, you've got peers, you've got religious institutions. All these play a critical role in terms of being able to enable and support adolescents to be able to experience that health and well-being that we all seek to achieve. And then after that, of course, then there's the ecosystem. Those are the neighbors, the social services, the industry, the mass media, and the local politics. And covering all that is the attitudes and ideologies of the culture. So the reason I showed this is that sometimes when we're talking about collaboration or when we are talking about addressing adolescent health, we tend to kind of think about it in terms of diseases. And yet, those diseases, as I said earlier on, are just symptoms. They are kind of telling us something about what this young person is going through. What are the risks? What are the opportunities? And where can we kind of intervene? So if we're going to kind of have successful collaboration, this is the way we kind of try to think about this. And we think about it first and foremost, your interventions have to be evidence-based. And I was glad to see Christine reference, the survey that has just been completed, which has informed, the Ministry of Health to be able to design and, such, a promising intervention. And again, the second point that we need to think about is we have again to move away from a disease-driven, because again, we focus sometimes too much on disease. And then instead of thinking about the clients, themselves, or the young people themselves, because without, focusing and redesigning our programs to address the needs of the young person in their entirety, then again, I don't think we'll be able to achieve and realize that health and well-being that we achieve for the young people. So shifting our mindset from disease-driven to client-centered approaches, and interventions that are going to be much more meaningful. The example I'll give you here is, for example, in Uganda, USAID at some point did realize that if they were going to have a meaningful impact in their programming, they chose to kind of focus on what they were calling the 15-year-old girl. And they centered their programming around this 15-year-old girl and saying, what is it that we need to do for this 15-year-old girl who is most probably about to drop out of school, about to get already pregnant, and maybe married or about to get married. And yet, she's got all these aspirations and visions and the potential to contribute to our society. So by centering their programming around trying to support this 15-year-old girl to realize her dreams, they were able to come up with much more collaborative and, integrated programming and collaboration across the sectors, the different sectors, to be able to kind of really make an impact in the way that they invested and programmed their resources. Of course, the interventions have to be multi-sectoral and multidisciplinary. Again, Christine did allude to this collaboration between the Ministry of Education and Health. I would argue that you need to go even beyond that. All ministries need to be brought together because each ministry has a contribution to make in terms of being able to address the adolescent health. They have to be inclusive and meaningful. There has to be inclusive and meaningful parental, youth and community engagement. And again, Christine did allude to this in the current, strategy that is being talked about. And they have to be equitable, accessible, and of high quality if they are going to have any meaningful impact. So to conclude, adolescent health and well-being is complex. It cannot be realized through vertical programs and requires deliberate collaborative efforts across sectors at the global and national levels. And I thank you. I hope that helps to stimulate some discussion in terms of how we can all collaborate and ensure that we do realize the right investments in order to get that compound interest that Christine referred to from the young people of today in the future. Thank you so much.
Thank you so much, Dr. Magwa. Quite elaborate presentation, highlighting, giving us the global perspectives on adolescent health, starting with the issues of the mental disorders, amongst many other complications that do arise, some of the issues. And also reminding us that what we see, especially in the health sector, are just symptoms in a society. But we need to analyze the root cause of this, and that the adolescents or the young people don't exist in a vacuum, looking at the various systems rising from the individual to the micro, the meso and exo, and the macro system. Oh, wow, I think that was great. So, and to finish up with talking about the key interventions, which must be evidence-based, the client-centered, multi-sectoral, meaningful inclusion of the parents, the community, and even the young people themselves. And that's those that these interventions should be of good, high quality, equitable, and accessible. And we'll be listening to, hearing much more of this today, part of it today, even in the panel discussion, and even tomorrow when we'll be looking at the risk-taking behavior, and then lastly on the 3 implementation science, and which also includes the multi-sectoral approach. So, ladies and gentlemen, allow me now to get back to Honorable Dr. Mbai, Dr. Joseph Mbai, who is the CEC Health, Murang'a County. Karibu sana, Mheshimiwa. I think we were with you last week, I think looking at the adolescent health policy. Yes, Karibu.
Thank you very much, Chair. I want to take this opportunity, first of all, to say I'm very delighted to be invited in this symposium. And if you can run my slides on my behalf so that we can go through them quickly.
Yes, Agnes will do that shortly. So you can just give us a few highlights as you maybe introductory remarks as the slide comes up.
As the slide comes, okay.
Yes, you have about
thank you.
15 minutes.
15 minutes, okay, thank you.
Yeah.
I just want to speak to this issue of adolescent health and say that it's an area which for us in the counties, we have started now giving it some attention. Basically, you realize that the population that is adolescent is quite substantial and we can't ignore them. And for us in Murang'a County, we started an initiative which we call Okoa Teenagers Initiative that looks at dealing with issues of teenage pregnancies, substance abuse, career development, and challenges that affect the adolescents, and especially when they are at school and when they live in the community. And what we have done as a county is that we do multi-sectoral approach. We are using the church, we use the community health volunteers, we use the health workers, we use the Ministry of Education, we use the chiefs, that is administration, and we also use the police and the judiciary. And the reason why we do this is because when you look at the challenges that affect the youth, the adolescents, you find that majority of it will border on gender-based violence. You look at some of them will border on issues of drugs and substance abuse. And you realize that there are some elements of criminality in that. That's why we felt it is necessary to have all the people involved so that the church can give us the moral aspect, and then the police and the judiciary can actually be able to explain even to the youth what are the possible outcomes if somebody engages in some of this. And we have seen it has worked for us, especially during initiation ceremonies when young boys are transitioning into adulthood. We just bring them together, we sit down with them and have a discussion on maturation, reproductive health, about how their sexuality actually matures and how they need to conduct themselves, how to become responsible men. And we teach them quite a number of things on that line. And we've realized that when we give them that information as they transition into high school, because majority of them go for initiation after class 8, we find that they get a lot of information that can help them to manage themselves specifically, personally, once they get into high school. So we have been doing that. And in the year 2015, we did an elaborate rehabilitation program of alcoholic addicts that targeted adolescents that were in high school and university. And we had quite a number of them, almost 600, which we rehabilitated that had several issues of drug addiction, alcohol addiction, and we were able to reintegrate them back to school, like almost 60% of them. And then in the year 2017, again, we now started championing against teenage pregnancy. And I am the one who started that program and have been spearheading it with the help of those other stakeholders I've mentioned. Now, in the interest of time, I would ask the rapporteur to get me to the next slide. Yeah, Murang'a County is one of the 47 counties, and it's located 85 kilometers from Nairobi. And we have 7 sub-counties and 35 wards. Yeah, let's move. Next slide, please. Next slide. That's the same information. Just to note, in Murang'a County, we have about 154 health facilities that have different classifications, like 8 level 4s, 32 health centers, and the rest are dispensaries. And why we started Okoa Teenagers Initiative is that we realized that there was an increased number of teenage pregnancies that were being recorded in our antenatal clinics. And we looked at the area that was quite affected, and we started there, Lower Gatanga. And the interventions were later rolled out to other sub-counties. And next slide. And what we actually normally do, if you look at our data, in the year 2017, we had that number of teenage pregnancies you see there, 4,499. And then in 2018, it overshot. And then 2019, we realized that it's still going very high. So this program of Okoa Teenagers, we decided now to go to the ground and look at ways and means of how we can deal with this issue. And we gave it several approaches. One, next slide. One, we looked at what are the ages that these numbers are coming from. And it was a shock to realize that even 10 to 14 years, we had quite some numbers. And one of the things that really annoyed me is one day I walked in the labor ward and I found a 10-year-old girl who had just delivered a preterm baby that did not survive because of low birth weight and other complications. And I think this young girl developed some complications we call and those people in the medical field, they know what is DIC. And I think to remedy that, the gynecologist recommended total hysterectomy, which I think was very painful for a girl of 10 years. So I started asking myself, who is this man who is responsible for a pregnancy of a 10-year-old girl? And when I followed that case, I realized that it was a man, 22 years old, who was a relative at the same time. And the family had just decided to put the story under the carpet. So I really got annoyed and I said, no, we can't allow this to happen. We must make sure we educate our boys. We must make sure we educate our girls. But again, we also deal with the criminals, because to me, I found that as defilement. I took it as criminal, and I went ahead and recorded statements with the police, with the mother and the girl. And to run the story forward, that young man was jailed for life. He's serving a life sentence at Kingongo prison because that was too brutal for a 10-year-old girl. And when we look at the ages of 15 and 19, we still had some cases, and we also started following them one by one. And for me, I decided that I will not use the DHIS. I will just go direct to the registers in the facilities where the girls are coming to deliver. And I was able to pick quite a number of them. Majority of their parents were not interested in following up the cases, but the ones who agreed to follow up, we helped them. Next slide. Yeah, in this slide, you can see the proportion of teenage pregnancies in terms of percentage as the years progressed. And if you look at the year 2021, because of our initiatives, we are now at 19%. And I know our target by the time we get to 2022, 2023, we should reduce these teenage pregnancies up to around 5% or less than that. Next slide. Then, how did we do this? First of all, we did integrated awareness campaigns using the COVID-19 sensitization. You are all aware that when COVID-19 came and lockdowns were done and schools were closed, all children went back home. So we used that opportunity to mobilize young girls and young boys, the adolescents, to create awareness for teenagers both in school and out of school. And every time when we used to go for those functions, we would do HIV testing. If we find any who is positive, we link them to treatment. We would give them kits. We would do pregnancy screening. We would even screen for STIs. We would give condoms to the ones who are eligible, and sensitization on alcohol and substance abuse. We have given even sanitary towels. For those girls who have also gotten pregnant and they have babies, we are looking at how do we protect them now from getting other babies, because we have also noted that those girls who become pregnant, chances of getting another second baby is very high. And with the help of their mothers, the ones who would agree, we would help them to make sure that they don't conceive again. Then we give age-specific AIC materials and linkage support services for survivors, including legal services support and community level mobilization by CHVs. For the ones who would become pregnant and HIV positive, or would confess that they didn't know whether the person who was them, would give them post-exposure prophylaxis after screening, and then we make sure that they are well guided. The next slide, kindly. So we had different actors: Office of the CEC, Department of Health staff, county-sponsored community health volunteers, Ministry of Education, Ministry of Social Services, Department of Youth, Children's Office, Office of the County Women Representative, Kenya Police Service, Judiciary, Ministry of Interior. And I found this integrated approach working very well for us, because if we had a case of a girl probably who has an issue and the mother or the relatives are bringing issues, we would use the chief and the police to assist us in bringing them to book and help us deal with the issues. So this is an approach that I would recommend because it has really worked for us. When all of us come together in this stakeholders system, we do integrated governance and deal with this issue, we are able to make sure that everyone is involved and there is no blaming one another, because the Ministry of Education is there, health is there, but we spearhead this ourselves and we incorporate all these other departments. Next slide. Achievements of the Okoa Teenagers Initiative. We have 6 breastfeeding teenage mothers supported to resume school. And we have another 11 who we are taking back to school that now they are on the pipeline. And we've been rescuing defiled teenagers to safety. And I actually get personally involved with these survivors. And I have had 51 cases completed with, right now, I think I have 37 concluded. That one has not been updated. And we have several cases ongoing. And currently, we are responding to 3 new cases of defilement. And we have increased access to HIV/STI services. And 3 teenagers identified with HIV positive and have since been linked to care. Yeah, next slide. Then if you look at my gallery, you will see some photos of the activities we've done. This girl, you see, although face has been hidden for humanitarian purposes, is a 16-year-old STD survivor and had been impregnated by a teacher. And the teacher had actually bribed 150,000 to the police to defeat justice. But when I took up this case, the teacher was rearrested, charged in court, and he was also registered with TSC and sacked. And right now he's serving a jail term of about 15 years in Muranga prison. And these cases, we have quite a number of them. We have a case where also a man who knowingly that he was HIV positive impregnated a 14-year-old girl. And after delivery and following up the case, we did DNA and it was 99%. And that young man, although the girl was 14 years, he was supposed to be jailed for 20 years, but due to the fact that he was HIV positive and he knew, the sentence was improved to life imprisonment, so that it can be a lesson to him and others who are doing that. Next slide. Next slide, please. You can see there a session with adolescent girls and young women. Sometimes they are targeting adolescent and boys and young men. Next slide. Yeah, you can see me there. I was with Initiate after talking to them about sexual maturation, brain development as young people, things that they need to be aware of, challenges that they would face when they go to Form 1 and the things that they need to worry about, drugs and substance education. And I realized that when these young boys are taught this thing, and when you tell them that there's the morality of sex and abstinence, they understand better. And you tell them also the importance of staying in school. Next slide, please. I know it's a gallery, yeah. We'll initiate at the Katora Catholic Church, Christ the King. All these had just gotten initiated, and I stayed there for a workshop of 2 days, mentoring them, educating them on issues of drug substance abuse, transition into being men. Next slide. yeah, a session with parents of pregnant teenagers. In this one, I had called parents of pregnant teenagers, and in this particular meeting, they were 146. So what we do with these girls, we talk to them, we encourage them, we give them support in terms of pampers, pads. The ones who are in school, we give them school books, and even getting bursary for them, those who want to go back to school and study. And we also educate their parents to support them and encourage them so that they can become better and responsible citizens in future. And we also tell them the mere fact that the girl has become pregnant does not mean that she's a failure in life. So as their parents, they need to support them so that they can continue with their life, and more so make sure that they don't also get engaged to get the second pregnancy. Next slide, please.
2 minutes, Mheshimiwa.
Oh, that is the last one. Next slide. It's not moving now. Yeah, sanitary towel distribution. We normally give girls sanitary towels. Next slide, please. Next slide, so that we see whether we are about to get. Yeah, you can see that is that's a workshop where I had 2,000 young girls and adolescent girls and boys. You can see the meeting is full there. Those are 2,000 young girls. I think this we did before COVID came, yeah. And those are sanitary towels that we were giving. This is Kahuya girls. It stopped moving. The slides are not moving. Oh, good. I think this is the last slide. This is now sensitization of CHVs on Okoa Teenagers Initiative. In Murang'a County, I have 2,470 community health volunteers who cover all the community units. And I actually involve them to monitor for us on the ground who are the girls that have are pregnant. They also follow for us even adolescents who are abusing drugs, and bring them on board so that we can talk to them, we can rehabilitate them, try to change their lives, and also train them. We train these CHVs on quite a number of areas where they really need support. And for us in Murang'a, we pay them a stipend of 4,000 per month, and we also give them uniform, and we also give them tools like glucometers. Some have pressure machines to check pressure, and we train them on many other aspects so that they can be able to deal with community issues. Next slide, if there's any. In conclusion, that is my conclusion. I always say the world suffers a lot, not because of violence of bad people, but because of silence of good people who keep quiet when bad things are happening. So how I pray that we shouldn't be the good people who keeps quiet when our girls are becoming pregnant, and we keep quiet when we know they are minors, they are being defiled, and we are keeping quiet. Young adolescents are getting into alcohol and drugs, and we are keeping quiet. So I want to ask everyone present in this meeting that we must stop keeping quiet, speak about this thing, and not stop creating it as normal for a girl below 18 years to come to labor ward and deliver. We must stop saying that is normal. Thank you, and God bless all of you.
Thank you, Mheshimiwa. Thank you for the great work you're doing, Okoa Teenagers Initiative. Wow, quite transformational. I think we can see many people in the chat congratulating you for the great work that you're doing. Remind me of the late Professor Wangari Maathai talking about the hummingbird and the burning forest. That little that you can do as an individual, just be encouraged to do it, because others also will join in this. In view of time, I request us to have our last presenter, then we get to Q&A, just a few of the comments that have been put here. the chart. Our next speaker is looking at the legal perspectives. Mheshimiwa, you've already highlighted a few of the things that you're doing, trying to take some of the cases in court and issues of defining even adolescents. Sometimes, should they give consent? Can they do this? How does that come in about? Milka Cheptinga will take us to the legal perspective of adolescent reproductive health. I don't know whether you have Milka?
Yes, thank you, Chair. And
yes,
thank
please,
you.
proceed.
Thank you. Thank you, Chair, and thank you for giving me an opportunity to make this presentation. Let me try and see whether I can get hold of the slide. Just a minute.
And you have 15 minutes, huh?
Okay.
Yes, thank you.
Able to see?
Yes, yes. Put
Thank
them
you.
on a.
All right, I'll be very brief. So,
please put them on
going...
a presentation mode. Yes.
Yes, are you able to see?
Yes,
Wonderful. I will just go over what the law says in Kenya, and then I will take you through emerging issues as well as the way forward, and then conclusion. Now, in Kenya, we have the Constitution of Kenya 2010. It provides that Article 2, Sub-Article 5 states that the general rules of the international law shall form part of the law of Kenya. Kenya is also a signatory of the International Convention on the Rights of Children, and therefore we are bound by its provision. We also have the Children's Act number 8 of 2001. And just a few definitions that were lifted from the Act that are quite fundamental is the term, the definition of an adolescent. Now, if you look at our Children's Act, that definition is not provided for. However, the terminology child means any human being under the age of 18 years. So that means the terminology adolescent falls under that bracket. Then we also have the child abuse defined to include physical, sexual, psychological, and mental injury. We also have the definition of child of tender years. That means a child under the age of 10 years. These provisions, these definitions have been provided under Section 2 of the Children's Act. Another important definition is the terminology early marriage, means marriage or cohabitation with a child or any arrangement made for such marriage or cohabitation. Interestingly, you realize that, you know, in Kenya, we are not supposed to legalize marriage when a child has been involved, because a child basically lacks the capacity to give consent. But of course, practically speaking, we have such arrangements. And as we go through, of course, I'll discuss at length. Now, what is important when you're dealing with issues relating to an adolescent is the fact that, remember, if I use the word child, remember is the same as now adolescent, because it's any person who is below 18 years. The best interest principle should be of paramount importance in every matter concerning the child. So whenever you're faced with any issue regarding the child, remember whatever is going to suit that child, to favor that child, shall be of paramount interest and consideration. Those sections have been reiterated under Section 4, subsection 2 of the Children's Act, as well as our Constitution, which is the supreme law of the land. Now, we have rights: the right to healthcare, right to education, right to privacy. And we also have important provisions under the Children's Act that detail on the need of children who are in need of care and protection to be, rescued or referred to the relevant organizations. Now, who are these children who are in need of care and protection? Orphans, ill, those who have been abandoned by parents, those who have been exposed to any sexual abuse, pornography, or whose parents find it difficult in parenting them, or guardians or parents who have been unable or unfit to exercise proper care and guardianship, truants, or any child found to be falling into bad associations. Those are children in need of care and protection. Remember, once you come across such, then you need to refer them to, Children's Department, the police officer, We also have the legal aid centers for assistance. Now, additionally, any child who is found to also have been exposed to domestic violence, FGM, these are also children categorized as children who are in need of care and protection. Now, under our laws, we have the Sexual Offences Act as well. It defines the term a vulnerable person. Remember, an adolescent is a vulnerable person. And we also look at Section 8 that defines that penetration with a child amounts to defilement. Remember again, the definition penetration can either be partial or full. Now, the penalties are based on the ages of the child. The younger the child, the more severe the sentence. So if a child is less than 11 years, the sentence is life imprisonment. That's the minimum. If a child is between 12 and 15 years and a person has actually been convicted under the Sexual Offences Act, then the sentence is not less than 20 years. And for a child who is between 16 and 18 years, the sentence is not less than 15 years. Now, emerging issues, and I know this is quite thorny, is the issue of contraceptives, whether we should give adolescents contraceptives. Interestingly, if you look at our laws, you remember that a child, from our definition, is any person below 18 years, and the child definitely has no powers to consent. But the general rule then means that you need to always obtain consent from the parent or the guardian in any issues relating to children or other adolescents. But interestingly, when you look at our HIV Prevention and Control Act, which we are also bound by its provision, the law allows a child or an adolescent who has engaged in behavior that is risky, or they are pregnant or they are married, then they have capacity to consent even in absentia of their parent or legal guardian. And that means a healthcare provider also has been given a capacity to even disclose their HIV status, as long as that teenager, that adolescent, that child has already said that they are either pregnant, married, or indulged in behavior that is likely to expose them at a risk of HIV. So contraceptives, yes, for treatment and prevention of HIV and unwanted pregnancies, but not sterilization. Confidentiality, always apply best interest principles. And then we also have pending bills. And remember, in a court of law, again, we don't really rely on bills. We rely on statutes, acts of parliament that have already been assented by the president, and they have the full force of the law. Now, looking at what happens on the ground as a practitioner, honestly speaking, it's important, and even basing on what my other colleagues have said, references have been made to numerous guidelines and policies, which I would, of course, propose that all this, if we are able to have all these different policies touching on matters relating to youth, put in together and anchored in law, it will give it the full force of the law. Because as a practitioner, most practitioners are not even familiar with the various policies and guidelines that we keep referring to them. So I would lobby that most of these are, of course, anchored in law to give it the full force of the law. Now, in issues regarding dissemination, that's what I'm talking about, that we need to have these policies widely disseminated. Even when you look at what legal practitioners make reference to in a court of law, we always go to the kenyalawreport.org and we look at the assented acts. And probably now the bills, which I've said, those are drafts, so they do not have the full force of the law. But the policies, the various policies, which are very good guidelines to the health providers, are not, the legal practitioners are not aware of the same. So it's important for us to disseminate them and also maybe even include in the Kenya Law Report, so that when we have judges making decisions, they're able to make reference to some of them and at least convince the court that this healthcare provider was faced with this scenario, but because it's not in the law, they didn't operate in a vacuum. We have some policies that allow them to do that. Then the other thing is community involvement. It's important for us to involve the community, and then careful and precise documentation of the procedure and evidence of violence and corroborative evidence in cases of litigation should be carefully documented. I'm aware of cases that have collapsed in many cases because documentation has not been done properly. Filling of the P3 forms, PRC forms done incorrectly. If there are contradictions, the criminal law is very clear in terms of the burden of proof has to be beyond any reasonable doubt, so that in the event of any iota of doubt, then that will favor the accused, and the accused is going to be acquitted. Then remember as well that we have the Children's Act that allow teenagers, their wishes should also be ascertained and considered. And it's also important for us to do the necessary referrals so that we're able to assist these minors who have been exposed in risky behavior, who are being abused, to be assisted. Then the other issue is always delay. We need to delay pelvic examinations and blood tests until when they are ready to explore alternatives. In conclusion, it's health that is real wealth and not pieces of gold and silver. Thank you.
Wow. Thanks a lot, Milka. Quite precise, taking us through the legal perspective in terms of the adolescent and how to handle these adolescents who legally fall within the age of bracket of a child by definition. And reminded us of the many areas. I think that many times in the health sector, we operate with the policies, the strategies, the guidelines, which gives us the framework to operate in. But in terms of legal framework, I think these are not considered, especially by the legal team. And emphasis on the documentation. I believe this speaks quite well to many of us. So we have a few minutes to share some of the questions, some of the comments. I just read a few. I think we have had the 4 presenters. Christine had 2 presentations, then Dr. Magua and the Honorable, and then lastly, Milka finishing on this. So the first one is just appreciating fantastic presentation. I think this is the time when Christine was making the presentation. Investing, Peter is saying, investing in youth and adolescent means investing in employment. I think this is just a comment. Their social well-being, not limited to sexual life. What is the ministry? I think you take note of this, Christine. The ministry doing to ensure youth and adolescents well-being in terms of able to access youth-friendly services. I believe this you covered during the presentation, but let me just get into the next. Jacob is saying, regards to the first presentation, I think this is still Christine. What is your take, especially for late adolescents' use of supplements or other similar mixtures concerning their body structure? I think you cannot drive in the 2. Dr. Christine?
Thank you, Dan. I think for us as the ministry, what we are trying to do is to ensure that we have quality healthcare services being provided at the youth-friendly clinics. In addition to this, the Universal Health Coverage Initiative of the ministry together the Ministry of Education, has launched the EduAfya that is supposed to look at ensuring financial access for adolescents in secondary schools to accessing the youth-friendly clinics. So that is what you're trying to do. We also have training programs. Some of the guidelines that I mentioned earlier in my presentation have training programs like the Adolescent Package of Care, where the healthcare providers are trained on this. The provision of adolescent and youth-friendly services is a training package on that. So once these healthcare providers are trained on those specific guidelines, they are now able to provide quality care at the health facility level. I think the issue of the supplements, I think I was not very clear on it. I'm just trying to wonder, are they the micronutrient supplements like the vitamins, or
the bodybuilding? I believe something like us looking at the body structure that's you see, or similar mixtures. There are some maybe young people would like to, I believe it also extends to others, no, but young people, what is it? What is your take on it? Supplements.
I think it's generally not recommended. We just recommend for natural food products, and because the body is growing and you don't want to interfere with the natural mechanisms of growth for the body. So we just advocate for healthy diets. We are also advocating for dietary diversity, that is consumption of food from different food categories. But not really so much the supplements that interfere with healthy growth. Yes, I think those are my responses. Thank you.
Okay, thank you. Then I think one of the presentations is a testimony that we have very good policies that will benefit youth and adolescents. However, there seems to be no resources that are committed by the government to budget at budgetary level, because this strategy will be useful if resources are allocated. I think that's something for the take in terms of resource allocation to implement them. I think Kenya generally we are endowed with policies, strategies, but now the next thing is implementation of the same, probably require more resources. There's a question which I think, where has it gone to? Yes, how about universities, students who mostly don't understand the sexuality, and most of them end up with STIs, unwanted pregnancies, most of which are aborted. Is there a policy addressing these issues? I think there's a session, there's a panel discussion coming after this. Can we reserve that question there? Unless, because I believe there's the SRH policies, adolescent policies on this. So let's get this and today and tomorrow, so that we have addressed the sexual reproductive health. Now, next is on teenage pregnancies. How do you stop? Is there a plan to provide more free condoms soon to stop the early teenage pregnancies? We are aware of the deficit of condoms nationally. Thank you. Oh, this is coming here soon. Again, I think let me just address that. And I think the elephant is in the room. How to balance adolescent program delivery with parenting in such areas of technology, sexuality, religion, among other aspects that are cross-cutting beyond health, and of course, heavily impact on the mental health adolescents. Dr. Magwa. I can see Dr. Mwanza, Professor Nzala.
Yes, may I say something?
Yes, please go ahead, Prof.
Yeah, thank you so much, guys, for this. This is just great that we are discussing this. I hope you can hear me.
Very well, go ahead.
Yes, yeah, we have great policies, and all the things that have been discussed are things that are really, as we sit in the various research institutions, these are really things that we are grappling with on a normal basis. What I would like to request, for example, is for us to go beyond just policies, to go beyond surveys, but begin to do some in-depth studies to really advise on the ensuring that when we empower these young adults, that we are actually empower them for good. Because you may prevent a pregnancy at 13, 14, and as somebody has just mentioned here, we sit at the university and we are seeing these girls getting pregnant at 18 and 20, which just causes as much disaster as anything else. We are organizing a research project at CAVI, and we really want to understand how the youth, adolescent, and young girls make decisions. If they are given 2 or 3 options, what would make them choose A or B or C? It is this that really policies should implement, rather than just blanket surveys and issues of looking at thinking that we are actually all the same. How do you make a decision at 13 years? How do you make a decision at 17 years? How do you make a decision at 20 years? This is actually things the ministry should be working with research institutions, because then this informs the program. Empowerment means that you give somebody ability to make the right decision at various levels as they grow. What I've seen in the presentation is that there are a lot of other groups involved, but Dan and Christine, you have totally left out research institutions. And yet we have a lot of work we are doing, so you need to involve us. Like the study we are now putting together, we want to bring in over 1,000 adolescent and young girls up to the age of 24 to really unpack at various levels, how do they actually make decisions? And it is this that can actually inform the kind of programs you need to put in place, so that we want to ensure that if we are going to prevent a pregnancy at 18, we want to prevent that pregnancy all the way up to past university. So what I would suggest, involve us as you do this, so that once you've done the surveys and where there are gaps, then give us the opportunity for us to do the research for you and give you exactly what is ongoing on the ground, so that it can actually inform practice. Because policy must go with practice, and that practice only comes from understanding really what is going on the ground. So anthropology is critical, and we have seen kids in Kibera make decisions very differently from kids in Kawangware, to just give you an example. So what influences that, and how do you design such programs? So Dan, I'll stop there, but that's exactly where I'm coming from. Over.
Thank you, Prof. Yeah, the research component, I think, as Dr. Margo mentioned, evidence-based, which interventions which you need to apply. There will just be a glimpse of it on day 3, role of implementation science, but keep the tab. I think we'll get back to you, and maybe in the subsequent presentations, maybe next year, have a chance to present on what you already started with at the university. I think lastly is, I think in the interest of time, this was to Honorable, do you include a multidisciplinary team? I think you already highlighted the actors, the various actors on it, the excellent presentation. And lastly is to Melka. The question is, are there guidelines dealing with adolescent who has been defiled by adolescents? I think this is probably more of a legal question. Being a teacher in charge of a health club, recently I had a case where Form 1 girl was impregnated by a Form 2. And I think there's been a bit issue of the peers, especially even at the primary school level, even at secondary school level, toto kwa toto. And there's also elements that the boys have been treated harshly. I don't know, what's your comment on this?
Yes, thank you. Yes, thank you, Dr. I agree that this is a very sensitive issue, but looking at the Sexual Offences Act, Section 8, it clearly defines that any person who is involved sexually with a minor below 18 years should be charged with the offense of defilement. Now, unfortunately, and I'm aware of a lot of cases in court whereby there's actually someone who tried to say that, to challenge that provision, Section 8, saying that it is discriminatory to the boy, because in most cases, the boy ends up being the, like the perpetrator, but the girl is always deemed as the victim. And we have a lot of cases for teenagers, of course, who are below 18 years, involved in what we call consensual sexual relationship. Unfortunately, if you strictly look at the provisions of Section 8 Sexual Offences Act, it doesn't allow anything like consensual sexual relationship. What the law says is that amounts to defilement. Now, the courts have also said that it is not the law that it is discriminatory, but when it comes to our police officers, the ODPP, most of them end up just deeming or charging the boy as the perpetrator and not the girl. But when you look at the evidence, in most cases, unfortunately, our boys are not the ones who go to the police to report that they have equally been defiled. We only end up having our girls, the young ones who are below 18 years, complaining that they are the ones who have been defiled. So I think there's also a problem in terms of sensitization, so that our boys are also able to know that they are supposed to go and report, and not just the girls alone. And I think also the other thing is the judges nowadays are allowing what we call diversionary measures, so that if there is no evidence of violence, then we can always request the court to refer these cases, even to have what we call an out-of-court settlement, sort of just referring them for counseling, so that we don't have, or we don't end up having very many young boys in prison. So that is something that I've realized, practically speaking, is happening nowadays. You can apply that as well, or also even filing a petition in a constitutional court, and the court is able to just look at the evidence and see what is proper, so that we're able to protect the boy child as well. Thank you.
Thank you. Thank you so much. I think in the interest of time, we stop at that. And once again, let me appreciate colleagues, ladies and gentlemen, help me appreciate our presenters this afternoon. Dr. Christine Wambugu, who is the head of Division of Adolescents, Adolescent and School Health Program, the Ministry of Health. Honorable Joseph Mbai, the CEC Health at Moranga County, Dr. Becca Magwa from USAID, and Milka Cheptinga, a legal practitioner, having great sessions that we have had this afternoon. So without much ado, let me hand over to my colleague, Dr. Pondi, to take over the next panel discussion. Thank you so much. I've been your moderator this afternoon, Dan Okoro, work with UNFPA. United Nations Population Fund. Have a beautiful session in the next one. Dr. Pondi.
Thank you very much, Dr. Okoro. My name is Dr. Pondi, and I'll take this next session, which should be very brief also. We are going to have a panel discussion. It's kind of been preempted from the answering of the questions, because in this session, we basically would like to receive questions from attendees, and we have a panel that will be available to address the questions. So kindly feel free to send in your questions that could be addressed by the panelists. Thank you.
So maybe Dr. Pondi, you can start with the ones which are on there, because as you can see, the session is on SRH for adolescents, the ones which are touching on sexual reproductive health.
Okay. So maybe I'll start with the first question here from Lillian Kabui. How about our university students who mostly don't understand the sexuality, and most of them end up with STIs, unwanted pregnancies, most of which are aborted? Is there any policy addressing their issues? And anybody from the panel can address this, especially Dr. Mbugu? I'm sure you may have something. Hello, Dr. Christine Wambugu. Are you able to take that?
Sorry, I didn't hear that. Could you kindly repeat the question again?
The question is, are there policies for sexual and reproductive health for adolescents who are in the universities, who mostly do not understand their sexuality and end up having pregnancies that end up in abortions? Are there policies to address their issues?
Yes, so I mentioned earlier in my presentation that we have the Adolescent Sexual and Reproductive Health Policy 2015, and that policy is currently under revision. So there is a policy.
Okay.
Thank you, and over.
I'm not sure if the question wanted to bring out the issue of abortion policy. We have one like on abortions.
We don't have an abortion policy.
Mm-hmm.
However, if someone presents to a health facility as they're miscarrying the baby or as they're losing the child, the healthcare workers at the facility are able to provide services to save the life of the person who presents the facility in such a state. But the government does not have an abortion policy. There's no such policy as an abortion policy.
Thank you very much.
If I may come.
Yes.
Yeah. So just to add on to what, to address some part of the question and what Christian mentioned, while there are no specific policy, I think the policies and guidelines that they are encompassing for all, respective of whether in the university. But I think the question which comes here is that there's a knowledge gap at the university, even amongst the university students. And that is the symptom that is being seen, or the signs which are being seen, is the issue of the abortions that are being committed, or the pregnancies and intended pregnancies. So one is the information amongst these, because we take note that some of these are the same girls who are in the university, at the secondary school level and transitioned into the university, and may not be aware of how do they prevent their pregnancies. So for those who, it's a question now, there should be a mechanism of teaching or passing information to the young people at the university level. I know there are certain programs, which are certain organizations which work with the university, who work with the universities to address the issues of reproductive health or general health, and more particularly looking at addressing also the unmet needs for family planning. Because if at all they are sexually active, yes, if they wish to use the contraceptives, yes, they can they access the contraceptives within the health institutions, within at the clinics within the university, or how else can they access that? But more important is just for them to have the knowledge on how to prevent those unintended pregnancies, or also for HIV and other STIs. So there need to be more programs directed even at the university level. So we should not be assumed that we're just looking at targeting the younger girls, but also we should also look at those who are in the colleges, the other tertiary institutions. Over.
Thank you so much, Dr. There's a question here for Dr. Mbai. It says, hello, sir, did you rehabilitate the adolescents free of charge, or how was the funding done? Together with a lot of congratulatory messages on the activities that you have done. And Dr. Mbai again, did you work with a multidisciplinary team? Okay, as we wait.
Honorable, I think he may have left.
Okay, okay.
But I can see Prof. Ndwati's hand is up.
Okay, Prof. Ndwati, welcome.
Thank you very much. And thank you very much. Very good presentations, very succinct. I want to make an observation about the adolescent justice in the tertiary institutions. So it's not just the universities, there's the TVET colleges as well. And the fact that there's a pronounced problem of unwanted pregnancy resulting in the termination of pregnancy by some of them. There are also issues of even substance use, alcoholism. And in some preliminary work, there are issues around intimate partner violence. I think from this discussion and the discussions we've had in the recent and not so recent past, I want to agree with the previous speaker that there's a gap in knowledge. If you look at the say comprehensive knowledge of HIV as asked about in the demographic health survey, the knowledge at the end of primary school is not very different from the knowledge at the end of secondary school. So there's a gap in terms of knowledge. But then when we come into university, we assume people are grown up and we don't teach them anything. I'm not aware of any program that is actually targeting comprehensive knowledge about one's reproductive biology for undergraduate students. We have the compulsory HIV course, but I don't think that is getting to the issues that the adolescents are actually facing. So maybe as an entry point, as an opportunity, is maybe the need to develop an advanced course or a senior course for university students around this issue, and to hopefully it may begin to address some of these challenges. Very many years ago, a study was done out of Kenyatta University, and they found that nearly 100% of first-year students were girls who were getting pregnant, and 50% of their babies did not survive. So it's not just the adolescent, the girl who's having a problem, but also the offspring of that relationship. And
sorry, Professor Ndwati, we lost you a bit.
Okay. Where did you lose me at?
At the study that you recently did.
I think my concluding message. No, this is there's a recent study. Actually, Dr. Christine there is aware of. where there are all these issues of just the pregnancies, the intimate partner violence. But I also referred to a study done, I think almost 30 years ago at Kenyatta University by the then Medical Office of Health in that institution, and found that at that time, almost 100% of the first year girls in first year, there were not very many those days, there were not many girls at university, but almost 100% of them were getting pregnant. And 50% of them, their babies were dying. So the problem is chronic, it's a node problem. And the policies within, so the problem doesn't only affect the girl, but it also affects our offspring. And the policies you have in this, say for example, within the university is, they'll provide you with contraception if you ask for it. I am not aware of the health department going out on, actively reaching out to the students to talk about their sexuality and prevention of STIs. There's a common undergraduate course in HIV, but how far that goes, I don't know. But if you're a girl and you get pregnant, your admission letter says clearly that the University Health Services will not provide pregnancy services. So the girls are actually, when they do get pregnant, they're at a hard place. They have to also vacate their room in the hostel. So it is an acute problem, and one which we need to address, both in terms of figuring out how to support in terms of services, but more important, maybe a proactive program on educating about their human sexuality, sort of an advanced course for college age, TVET college level students. So I hope you have heard me now.
Yes, we've heard you. We've heard you loud and clear, and we have understood the issue of and the neglect of the university level girls. Okay. I would like to put a question to a nurse who works at Rafiki Clinic, adolescent clinic in MTRH. Because of the issue of consenting for contraceptives for adolescent girls, I would like to hear their experience with how they manage to give the adolescent girls contraceptives, the ones who are below 18. So welcome, Rahab. Hello, Rahab. Okay, she may be having challenges joining. We can take another question as she joins. There was a comment here about how we can have an interface between the laws and the policies that we are creating. As the healthcare system, we are creating lots of policies, but it seems there's a barrier or a gap between the policies and the laws. So could maybe a response from somebody in the health system, and then a response from Milka on how we can bridge this gap. Anyone? Milka, do you want to go first as we, how we can?
Yes, thank you, Dr.
Thank you.
Yes, I believe the first step should be just ensuring there is also consolidation so that we don't have so many fragmented pieces of policies and guidelines that we are making reference to. But if we would move forward and have them consolidated so that you have probably one policy or one guideline, and then again take it a little step forward by anchoring them in law so that they're able to obtain the full force of the law should be the way to move forward. And I'm aware of the fact that as practitioners, we used to have very many acts of parliament relating to land law, for instance. We had over 5 different pieces of legislation, and most practitioners, even in a court of law, you would literally get lost as to which piece of legislation you should refer to. So I think it's important for us to just consolidate and then move it to a little step forward and having it anchored in law so that we are totally covered. But as I said again, in as much as the Children's Act does not expressly allow us to do what we are doing, we are covered by the HIV Prevention and Control Act that says that in the event of just having a minor who says, I'm pregnant, I'm married, or I've engaged in behavior that is risky or likely to cause me to contract HIV, then you are allowed to then give care. You're allowed to test. So we are covered by the HIV Prevention Control Act, which also has a very important provision that it actually says that the act supersedes any other act in matters relating to HIV. So contraception is allowed because now if you're telling, if this minor says I'm sexually active, you can give them condoms to tell them that it's important for you to prevent the other person. Yeah, thank you.
Thank you so much, Milka, for that response. I would like to hear from the ministry as well with regard to the experience with trying to work to interface between policies and the legal system.
1 minute. Can you have the lawyer clarify that last statement? Because I don't know of any law that supersedes the Children's Act where children are concerned. So I think, and the protection of children is anchored in the Constitution. So maybe the lawyers should advise us.
Thank you. Now, if you look at the HIV Prevention and Control Act, I believe it's section 40 something, I think 46 or 45. It specifically says in matters relating to HIV/AIDS, testing, disclosure, then the provisions of that act, HIV Prevention and Control Act, supersedes any other. Supersedes any other. So that actually means that as long as you're dealing with HIV issues and the minor here has already confessed and admitted, I am married, I have indulged in behavior that is risky, then I'm pregnant, you can go ahead and test for HIV.
No, let's have an independent opinion. We are asking, I think there's a lawyer in the house. I was at the policy meeting last week on adolescents, and I don't believe that's what was said. So please, can we have an independent statement on that matter? Does the HIV Act supersede the Children's Act? And this is a really important question. Does the HIV Act, the fact that you're a child and being violated, mean now then usurp the laws that protect you?
Professor Ndwati, can we put that for follow-up?
Yes, Dr. Pondi, I think it's very important because we say that if you're under 18 years, you don't have the capacity to consent to consensual sex or whatever. So even if a child comes and says that what they're doing it's delinquent, we then now apply a law that even usurps the parental authority over that child. As health, we interact with this child only once, once every 3 months or once every month. This child is at home with parents or others all the time. So it's important I think we need to understand what it is, because I think about children, and that includes the adolescents.
Thank you very much.
So adolescents, HIV positive adolescents also include children who are born with, who are survivors of perinatal infection. And very often I find they are assumed that because they are positive, they must be, busy passing infection around with everybody. And you start treating them like an adult, and yet they are children, protected under the Children's Act.
Yeah. I hear you.
Yeah.
I think we can put that so that we may not get the whole answer today, but we can put that on our to-do list, and then we can get somebody to speak to us tomorrow. Is that fine?
Yes, that is fine. Actually, and I appreciate the person who just presented and honestly presented what they're doing. It gives us an opportunity to discuss and arrive at the best position for our youngsters. Thank you.
Thank you very much. Okay, as a continuation of that now, because sometimes we have different things happening on the ground, we want to hear from what the nurses encounter who actually give the contraception or have to talk to the adolescents about contraception. So I would like to welcome Rahab to give us her experience as a nurse in charge of our sexual and reproductive health at Rafiki Clinic in Eldoret. Welcome, Rahab.
Thank you so much. So how we deal with our adolescents, especially those who are 18 years and below, now that they can't consent for us, we usually have a sit with them. We counsel them and educate them, and then we come to know about their sexual relationship. When they tell us that they are those ones who they are ready to tell their parents that they are sexually active and they want to get the family planning methods, so we involve the parents and they consent for us against the child. But there are those children who doesn't want their parents to know, and they really want those contraceptives. So what we do, those are the children that we call them the mature minor, and we have our legal team that we work together. So these children who cannot come with their parents, we make sure at least they countersign against our books, and we educate them well about the side effects and all other things. And then with the help of our legal, because sometimes the parents may come and question why we had to give to this child. But once they've known and you've sat down with them and they've known all the consequences, all the risk, and what they are going to get involved in, that's the time it's like we assent them, and then we give them the contraceptives. Those are the special cases, only when you have sat down with them and then you've known that at least they are sexually active and you can't deny them.
We appreciate very much, Rahab. Have you ever, in your experience, had a parent come and complain about having given contraceptives on adolescent?
Yeah, they have been there. Okay, one of the experiences, there's one of the girls who came, she wanted the contraceptive, but after a while, the parent realized that she was using the contraceptive. They came with the parent to the clinic, but when we sat down with the parent, and the child, the child told us that she doesn't want to remove the contraceptive, but the parent insists that she wants. So we had to sit down with the parent and the child also and tell them about the consequences if they are ready to, because already the girl had one child. But now the parents didn't know that the child was sexually active again. For them, they knew that they separated the boy and they're not sexually active, and the girl is back to school. But in real sense, the child was still sexually active with even more than one partner. That's the reason now they had to sit down and think with us. But at the end of the day, the parents had to agree, because seeing now the consequences that they're going to get, maybe this child again is going to get another child on top of one that she has, they had to agree, and they allowed the girl to continue the contraceptive.
Thank you so much, Rahab, for sharing your experience.
Thank you.
Thank you so much. We appreciate that.
Okay,
Any other questions that we may have? Okay, there were a bit of comments on the issue that Professor Duarte has touched on, so I think we will not dwell so much in that, as we will get more responses tomorrow. So are there any other issues that we may need to address? We are coming to a close. Just to take us back, remember we started with the presentations from the Ministry of Health. We went to USAID experience. We may have forgotten some of the questions we had from our earlier presenters. Then we had a presentation from Dr. Mbai before we went to the legal perspectives. Okay. So I would like to then end my session and take back this meeting to Dr. Kinuthia. Kindly, Dr. Kinuthia, welcome back.
Dr. Pondi, thank you. This is Dr. Karen Gopton from KNH Research. Apologies for Dr. Kinuthia. And we just want to really thank you very much for taking us through this very important session, and to thank our presenters. Maybe in the remaining very few minutes, we can have just the last comments from our main presenters before we close it off. Maybe we can start with Dr. Christine Wambugu, your last final comments as we close off.
Thank you so much, Dr. Karembo. I think it has been indeed a pleasure to have this session and to interact with my colleagues and on this critical issue of adolescents. I've taken quite a bit of notes on the discussions and the deliberations around the legal issues surrounding adolescent health and about the suggestion of having a consolidated policy. I think these are some things that we can look at towards collaboration across the different line ministries that touch on adolescent health. I think I had mentioned the Ministry of Education, Ministry of Gender, Ministry of ICT and Youth, so that we can have a common joint position on adolescent health, and to see how we can create synergies so that whatever we are working on builds and potentiates the other ministry, so that we are not duplicating efforts, because it's this exact same adolescent that we are reaching out to. So I'm grateful to KNH for providing this session, and I'm grateful to all the practitioners who are they're seeing the adolescents in Kenya and taking care of their health needs. And so with those few remarks, I would just want to appreciate the session. Thank you so much, Dr.
Thank you very much for giving us those insights. Dr. Baker Moga, I can see you're still with us. Thank you so much for your session. Are you able to give us your comments too?
Yeah, no, again, just to echo Christine's, message, to thank, the organizers for organizing this important opportunity for colleagues to share and learn from each other. I did learn a lot listening to the presentations, from the ministry and from, the county in terms of what's going on. And it's quite reassuring that they are all, taking the issues of adolescent health or youth health, seriously, and beginning to take action and also using more and more an increased, multi-sectoral approach to address this. I think I'd like, to really, thank you most sincerely and encourage you to continue to listen to each other and learn from each other. Thank you.
Thank you very much, Dr. Baker. We have Milka Chaptinga. You can also give us your last comments, and thank you so much for your highlights on the legal aspects.
Okay. Yeah, thank you so much for giving me this opportunity to make my presentation. Probably just commenting on what has transpired from the legal perspective. I would just like to make these few remarks saying that interpretation of the law, by the way, as legal practitioners, we also interpret the law differently. If you look at our Supreme Court judges, no wonder most of the time you realize the majority win, but it doesn't mean when there is a dissenting opinion, the person who has dissented is on the wrong. But law, we may end up interpreting it in very different ways. But probably allow me just to comment on this, that because I had not finished, the specific section under the HIV Prevention and Control Act is section 45. Then the terminology used is the word may, that a minor may consent. And now that means that we remember the Children's Act and the Constitution, of course, provide the general rule. But we have exceptions, and the exceptions have been allowed under the HIV Prevention and Control Act. Now, if you are to marry the issue of documentation, when you are dealing with the issue relating to a minor, document that you have already exhausted the general rule, that you have asked them, do we involve your parent? Do we involve your guardian? If they say no, but they have already confessed of these other existing circumstances, that they are married, pregnant, indulge in behavior that is likely to be risky, then the word used there is may. You may allow them to consent in writing, and that's allowed under section 45 of HIV Prevention and Control Act. Anyway, thank you so much for giving me this opportunity. And learning is also a continuous process. Thank you.
Thank you so much for your highlights, Milka. We'll definitely continue with this conversation, a very tricky issue that has raised a lot of questions. We'll definitely continue with this conversation in our next sessions and even on going forward. We want to also thank Honorable Joseph Mbai Nabsesha, who gave us his session on the county initiatives. And we also want to appreciate our moderators, Dr. Okoro, who was with us earlier, and also Dr. Ponde. We really do thank you for being with us and for taking us through the sessions. We want to appreciate Prof. Nduwati. Thank you so much for coming in and for your views, and we are looking forward to your session tomorrow as we delve into matters understanding the adolescents and these risk-taking behaviors. We are looking forward to that session coming tomorrow afternoon. And we thank Prof. Anzala too, who was also with us and contributed to this conversation. For participants, thank you for staying with us till this time as we're coming towards this end, and for contributing to this conversation, for your questions and your comments. We really do appreciate, and we do welcome you for our upcoming sessions. We'll continue with the symposium tomorrow in the afternoon and on Friday, looking at different aspects. And just to highlight, even tomorrow, we will go all the way up to the evening. We have a session on the HPV vaccine at 7 p.m. to 8:30 p.m., for which you are very welcome to take part in. And for any questions in regards to how we get a presentation, you can forward that to knh.research@gmail.com. We'll have the sessions uploaded in our website for specific sessions. If you'd like the presentations, once we have them in consent and you'd like a specific session, let us know, and we'll see how to go about that once the consent has been taken. But we'll have our sessions which have been recorded, and it will be there in our KNH websites. We thank our partners. As you can see from the logo, we have the Ministry of Health, who have come in strongly. We have CAHISA, who have been supporting us in HIV implementation science in matters adolescents. At the National AIDS Control Council, we have UNFPA, which has been supporting this the Zoom sessions for this period, and we really do appreciate University of Nairobi. We've had a very good collaboration with them. So I'd like to put this to an end. We really do thank you. Do join us. For those which have not been answered, we'll continue the conversation tomorrow. Karibuni sana. Have a lovely evening. Thank you.
Thank you.
Thank you. Bye.